So thank you very much for inviting me to speak. Dear audience, today I will give you an insight regarding my PhD topic, which is the value of digital technologies in orthognathic surgery. Accurate maxillary positioning is crucial in orthognathic surgery since small deviation can affect both function and aesthetics. Splint-based orthognathic surgery can exceed the 2 mm discrepancy, which is the clinically acceptable threshold, highlighting a key limitation. We conducted a systematic review and meta-analysis comparing the splint-based orthognathic surgery, the splintless approach, finding out that the splintless approach improves the accuracy by 0.5 mm. Although patient-specific implants cost at least twice as much as the splints, clinicians may still consider the selective usage in cases with clear clinical benefits. Future studies should focus on long-term outcomes such as skeletal stability and soft tissue positioning. Policymakers should develop clear guidelines, whereas insurance companies should support the selective usage of patient-specific implants. To briefly introduce myself, my name is Darius-Valentin Sandu, and I have graduated the Faculty of Dentistry at Grigore Popa University of Medicine and Pharmacy in the summer of 2024. And I started this PhD journey with a clear vision, which is to create the best orthognathic surgery outcome by virtual planning. And I can only do this by following my mission, which is to find the best surgical approach. About my specific goals, I have two ongoing projects. The title of my first project is Investigating the Effectiveness of Patient-Specific Implants and Surgical Templates over Splints in Orthognathic Surgery. So, orthognathic surgery is the surgical repositioning of the jaws designed to correct conditions of the jaw and lower face. After the osteotomy of the bones is done, the bony segments are usually placed into the desired position by using a splint. But they are associated with several disadvantages, such as they require the vast experience of the surgeon, and the surgery is not as accurate as we wish to. To overcome all these disadvantages, new approaches are available, and they are represented by splintless orthognathic surgery by means of either patient-specific implants or surgical templates or guides. The splintless orthognathic surgery has many advantages, but the most important one is that it is associated with very high accuracy. Therefore, our aim was to find the best surgical accuracy for orthognathic surgery. We developed a clinical question: what is the best approach to translate the virtual plan into the operating room during orthognathic surgery? Our population is represented by patients undergoing orthognathic surgery. The intervention is represented by the splintless orthognathic surgery by means of either patient-specific implants or surgical templates. The comparator is represented by the virtually planned splints, and our main outcome is the accuracy of the surgery. We hypothesized that patient-specific implants and surgical templates are superior to splints in orthognathic surgery. And by answering this question, we want to improve the surgical outcome for these patients. This is our search strategy structured on two domains. We conducted our systematic search on 15th of November, and these are our results. We started off with around 8,500 articles and cut them down to 15 eligible full text. And with the help of forward citation, we were able to find a very recent published article and to include it into our analysis. So our outcome is represented by the accuracy, which can be assessed as linear accuracy and angular accuracy in non-segmental left foot osteotomies in all three axes of the space. In the first forest plot, we can assess the linear accuracy along the y-axis or the anteroposterior axis. So, as I previously said, the accuracy is paramount, and it is usually measured by a mean deviation from a 3D preoperative planning. This means that the lower the mean deviation, the higher the accuracy of the surgery. In the third mark column, we can see the mean difference between the mean scores for each study, and we can see that all of the values are negative, consistently favoring the splintless approach. We included 9 articles. Out of these 9 articles, 4 were RCTs and 5 were retrospective observational studies. Having a look at the heterogeneity, we can see that it is moderate, and this could be due to many reasons. However, it didn't affect our outcome because the pooled mean difference is minus 0.49, and the result is statistically significant. This means that splintless orthognathic surgery tended to improve the overall accuracy by almost 0.5 millimeters in the anteroposterior axis. In the next forest plot, we can assess the angular accuracy around the anteroposterior axis, so-called roll, which is measured in degrees. The story about the outcome is exactly the same. In this case, unfortunately, we couldn't do the subgroup analysis for the surgical templates due to the lack of reporting this outcome in the articles. Looking at the heterogeneity now, it's even bigger, but again, it didn't affect our outcome because the pooled mean difference is minus 0.48, and it reached the mathematical relevance. As for the progress of my first project, the first version of the manuscript is done, and it was sent to my team on May 12th, and soon it will be sent for the internal review. Some strengths of our study. To the best of our knowledge, this is the largest patient pool to date on the subject, and we were fully compliant with the international standards. But we also have some limitations, such as a low number of included studies with a low number of patients, different study types, and we could not perform meta-analysis for our secondary outcome due to poor data availability. Some conclusions: patient-specific implants and surgical templates consistently improve the surgical accuracy. The highest improvement in translating movements was along the y-axis. And although patient-specific implants have many advantages, the cost barrier is still present. Therefore, as an implication for the practice, surgeon may still consider the strategic use of patient-specific implants in cases with clear clinical benefits. On the other hand, implication for research, there is a high need of assessing long-term outcomes such as skeletal stability, soft tissue position, and also direct cost-effectiveness comparison. And there is a high need of strong and robust RCTs. As associative events, I already had the opportunity to present my results at the first patient-specific implants in maxillofacial surgery conference, which was held in Belgium, Bruges. And I will also have the opportunity to present my results at one of the biggest congresses organized by the Italian Society of Maxillofacial Surgery, which will be held in Naples, Italy, mid-June. The title of my second project is Investigating the Effectiveness of Fully Digital Occlusion Planning over Physical Dental Model Approach in Orthognathic Surgery. So, back in 1960, the conventional model surgery was the only way a surgeon could plan the orthognathic surgery in advance, and it was used for decades to establish a stable occlusion. But it is associated with many disadvantages, such as it involves a long clinical and technological algorithm, dental casts must be physically stored and may wear off or break, and the impression taking for the process, for the patient is uncomfortable. In the digital era, intraoral scanning and virtual planning are valuable tools, and the use of the intraoral scanning has two approaches in occlusion planning. There is the semi-virtual method, which still uses physical models that are to set up the occlusion, that are digitalized later with an intraoral scanner. But on the other hand, there is also the fully digital method where the dental arches are scanned directly on the patient with an intraoral scanner, and the occlusion is set up directly on the virtual software. Therefore, our aim is to determine if this extra step represented by the fabrication of physically dental models is still needed. Our clinical question: is the fully digital occlusion planning a paradigm shift in the virtual planning of orthognathic surgery? In order to answer this question, we use the PICO format, where the population is represented by patients undergoing orthognathic surgery, intervention is represented by the fully digital occlusion planning, the comparator by the dental model approach with the use of either dental cast models or 3D printed models, and our outcomes are accuracy and reproducibility. And we hypothesize that the fully digital occlusion planning is more efficient than the physical dental model approach. And by answering this question, we want to improve the surgical outcome for the patients undergoing orthognathic surgery. As a summary, my planned submission dates are June 2025 for the first project and hopefully November 2025 for the second project. And at the end of my presentation, I'd like to leave you with my quote, which says, "The future belongs to those who believe in the beauty of their dreams." And I would also like to thank you very much for your attention.
Thank Thank you very much for your nice presentation, and congratulations on your progress and your networking tools. So, questions. Do you have any questions? There is a question.
Thank you for your presentation. In your second project, you mentioned this intraoral scanner. How does that scan? Like, is it just a physical picture, or like, how does it scan?
It's a normal intraoral scanning. I mean, scanner is a device used by the dental
scanner. Like, how does it work?
It captures the picture of the dental arches, and
so it's a picture. It's not like a
scan. So it's a 3D scanning. A STL file, which is imported directly on the software.
But it's like, does it have radiation in it or something, or it's just like an actual picture?
I don't. To be honest, I don't think it has radiation. No, there are different types of intraoral scanners and different softwares, but no, it's just the 3D picture of the dental arches.
Okay, thank you.
Of course.
Thank you very much for your presentation. I have a question regarding your first project. In the very beginning, if I understood correctly, 2 millimeter was the threshold.
Yes.
For these surgeries in accuracy. What do you see in the literature? What is this threshold based on?
Anthropometric measurements and other studies that considered that this would be the clinically acceptable threshold, and also what the human eye can see as symmetry or asymmetry.
I see. According to the results, even with the splints, the surgery performed with splints, the results were well under this 2 millimeter threshold. So, are these results? I understand that they are mathematically significant, but are they clinically significant?
Thank you very much for your question. It is a very good question. So, yes, indeed. Usually the accuracy using splints, I mean, if we are looking just at the mean deviation, it seems that the surgeries are accurate, but we also have to consider the standard deviation. So if we are going back to the forest plot, let's say the criema, the fourth article. So we can see that the mean deviation is 1.94, but the standard deviation is 1.55. So we also have to consider this. And besides the improved accuracy, patient-specific implants and surgical guides have also like many advantages: preoperative screw planning of the screws, position of the screws. They indicate the exact planned osteotomy line. They can position the maxillary bone in the vertical axis, which is not possible with the splints, because by using the splints, usually the surgeon has to make some intraoral measurements and with the caliper and to take some reference points. So regarding just the accuracy, I don't think that the results are clinically significant, but to be honest, I would use the patient-specific implants or the surgical templates instead of the splints.
Thank you very much. It was a very good answer. If you present at the Italian Congress, you could also argue that the bigger the accuracy, usually these cases need a further orthodontic therapy, and exactly. the duration of that orthodontic therapy will be shortened. Sure. I will be also presenting there, so see you in Naples.
Of course.